the consumers, the advocates, the individuals experiencing disabilities for being here and your effort to raise this awareness with us individually, and then hopefully collectively we'll be able to talk about the issues and concerns that you have shared with many of us. Again, I'll just share a couple of thoughts, my opening remarks, which are primarily that access to healthcare should be equal in Connecticut. We know that it's not as equal as it should be, and more so for individuals with disabilities. We've heard you loud and clear in the last conversations we have had. This afternoon, when you spoke earlier, we heard you at that time as well. And we also hear you and looking forward to listening to your concerns and comments as well. We know that our state can do better. And we are hoping that in our conversation, we will be able to learn how we can do better at various levels and what will be the roadmap to make us move in the right direction. And as we look at the roadmap, we will need to also explore what would be the resources that it would take. And we need to make sure all the stakeholders are together, learning from you, listening to you, and looking at the next steps. The reality is 1 out of 2 individuals over the age of 65 experience disabilities. 1 in 4 experience disabilities. 1 in 4 women experience disabilities. The number is 2 over 5 for the African Americans and the Latino community members. Their numbers are higher. So the people in our communities this is one of the faster growing segments of our society. And we have not done as good a job to take care of your needs in the healthcare systems. I'll just touch on a couple of areas, and then I'll have my colleagues speak as well. One of the areas is that we will need a culture change. We will need a culture change that includes educational change and recognizing that we have to have empathy, understanding, commitment to be able to take care of individuals with disabilities. Now, isn't that what many of the people who are interviewed when they speak and they're in various levels of healthcare, they want to take care of the community. And we need to make sure that as they do, that empathy that started from day one should continue on till the lifetime. And that's when we have to have those conversations. The other thing that we have to talk about is the physical access. The physical access requires us to have investments in the physical structures, technology, and also look at innovations and opportunities on that end as well to be able to see how we can do better. So there are gaps. We are hoping to be able to learn about those gaps and look at what the strategic plan we need to have as a state, and then hoping to have some of those issues answered in some respects, or actually beginning to answer some of those questions. With that, I will ask my colleague, my co-chair, my friend, Representative McCarthy-Vahey, to have her opening remarks.
Thank you so much, Senator Anwar, and grateful to be here with our Human Services colleagues as well. And I think Senator Anwar really put a wonderful frame around our conversation. I'd like to add to the thanks, especially Rep. D'Amico. We spoke earlier during the press event, but thank him for his ongoing advocacy, and so many others who have been at this work for quite some time. And in particular, also would like to thank Bev Henry, our wonderful administrator, who helped bring us all together today. I'm really looking forward to hearing directly from all of you today. Thank you, Senator.
Thank you. I wanted to see if the ranking members from the Public Health Committee were here. I'm gonna check if I'm seeing online if Senator Summers is there right now. I don't see her yet. There's been a family responsibilities that she's addressing. And then I wanted to see if Representative Clarice Dietra is here. She will be joining us probably.
Thank you, Mr. Chair.
Oh, good.
Thank you, Mr. Chair. I'll make it short and sweet. I'm at a red light, so I just want to thank everybody for being here today. And I know this is an important conversation we need to have, and I'm looking forward to the continued conversation and helping out our disabled population to do whatever we have to do to get them the services that they need in the state of Connecticut. Thank you, Mr. Chair.
Thank you so much. And next to me is Senator Lesser, who's the chair of Human Services Committee. Senator Lesser.
Thank you very much, Senator Anwar, and it's great as well to work with Representative McCarthy-Vahey and the members of the Public Health Committee. On the Human Services Committee, we are, as I mentioned at the press conference, really limited to working with the Department of Aging and Disability Services and the Department of Social Services, which are two important stakeholders here. You know, I am cognizant of the fact that 33 years after the passage of the Americans with Disabilities Act, we have taken many steps forward, but we also have a lot of work to do to ensure quality and access to care for people with disabilities in this country. And certainly in Connecticut, we have more work to do. We heard some really incredibly moving stories from advocates this morning. I think we're going to hear a lot more very shortly. And I think we're very eager on the Human Services Committee to get to work. This year, we worked on expanding access to Husky through the Husky C program and also expanding access to the MedConnect program. But we also know that we need to look at quality for people who are on those programs. We in Connecticut don't have a blanket non-discrimination law for healthcare, unlike on the federal level. And that I think is a problem, a source of some of the issues that we're facing. But I'd like to work with the advocates here and see what we can do working together, our two committees to tackle this issue and ensure that everyone in the state is treated with dignity and respect and has access to high quality healthcare. And with that, Mr. Chairman, if I may, I'd love to turn it over to my co-chair, who I see is online, Representative Jillian Gilchrist.
Thank you, Senator Lesser, and thank you, Senator Anwar and Representative McCarthy-Vahey and members of the Public Health Committee and Human Services Committee, and to our staff for organizing today, and to all the folks who are going to present. I echo much of what has been said. I was shocked when this was brought to my attention. I want to recognize Representative Mike D'Amico, who brought this to my attention probably 2 years ago at this point. We talk so often about the importance of primary care and preventative health care, and it's just a complete disservice and just wrong that those with disabilities are unable to access the healthcare that they need. So I'm looking forward to this conversation and seeing what we can do to move our state forward. Thank you.
Thank you so much, Representative Gilchrist. And I wanted to ask the Human Services ranking members, Representative Case.
Thank you, Senator. It's good to be here. One of the reasons I became a legislator was for this very reason. And growing up my life, you know, taking care of my brother and bringing him to appointments and doing all that. So it's myself and won't speak for Senator Seminara, but we both personally have lived it with family members. We get it. We need to make the change. A lot of things have opened up. As I said in the press conference earlier, after COVID, we learned a real lot about accessibility and getting to appointments and working it through. And once you've lived it, as I did with my brother, I mean, it hits home. And we just need to get that across to many more people within this building so that we can make the definite change. But thanks for coming.
Thank you. And Senator Seminara.
Thank you. Once again, I echo all of my colleagues, what they've said. And in addition to that, I said it earlier, this is long overdue. And we really need to make improvements. And I'm hoping that we make improvements sooner rather than later. And improvements that include people with disabilities having independence and having dignity in the services that they so very much need and deserve. So I look forward to hearing the rest of you today. I was moved by what I heard earlier today in testimony, and I'm sure I'll continue to be moved as we continue through this process, hopefully with a very fruitful outcome. Thank you so much.
Thank you, Senator. Next, I'll just ask Representative D'Amico to have some remarks as well. Representative D'Amico, you're one of the most passionate advocates on this issue, and thank you for your activism and advocacy and persistence. Thank you.
Thank you for those kind words, Senator Anwar. I think what you meant was I'm a thorn in your side but that's okay, because this is important, and I have to acknowledge, and I won't go on for long. I have to acknowledge that the leadership of the Public Health Committee, as well as the leadership of the Human Services Committee, took the initiative to put this together. And Senator and Representative, you both kept your word. You said that we're going to do something about this. We're going to have a meeting in the summertime, and there's 8 days left to summer, so we just got it in on time. I want to thank all the advocates who are here, and we need to identify the problems and then identify the resources that will get us to a solution. And I think that we're well on our way to doing that with this meeting today. So thank you, thank you, thank you.
Thank you. And moving on, we'll have the advocates and consumers speak, and then the first person on the list is Ruth Grobe. And Ruth, do you want all the people to come up front or one at a time? It's up to you. Why don't we do one at a time? Okay. You can go there and press one of the buttons and the light will turn on and you're ready. Perfect. Welcome.
Thank you. State Representative D'Amico represents a district that includes New Horizons Village in Unionville, an independent living facility for people with severe disabilities. In 2005, as chair of the Farmington Human Relations Commission, I scheduled a commission meeting at New Horizons to hear from the 101 residents about any problems they might be having in receiving equitable treatment in our town. There was so much to talk about that over time, a number of New Horizons residents have joined up to engage in advocacy with other allies in the town of Farmington and beyond. The advocates call themselves the Citizens Coalition for Equal Access, or CC=A, and healthcare equity has been a prominent concern from our very inception. Key supporters have been Dr. Ray Elling, a founding faculty member at the UConn School of Medicine, and Dr. Peter Deckers, Dean Emeritus of the UConn School of Medicine. In the past few years, the issue of accessible medical diagnostic equipment has also been adopted as a legislative priority by the Connecticut Cross-Disability Lifespan Alliance, a statewide group of parents, self-advocates, and providers. CC=A self-advocates have been sharing stories similar to the ones you will hear today for many years. But our advocacy didn't get much traction until Dr. Mary Beth Bruder, from whom you will hear shortly, introduced us to medical students who were part of the Disability Interest Group at the UConn School of Medicine. In their hands-on experience in various medical facilities, the students had observed patients with disabilities receiving substandard care because of the lack of accessible medical diagnostic equipment. They confirmed what our advocates with disabilities had been saying for years. For the past 2 years, Citizens Coalition and UConn medical student advocates have been meeting with a number of representatives who are here today as part of an informal, accessible medical diagnostic equipment task force. And we advocates would like to thank task force members Karen Buckley of the Connecticut Hospital Association and Barbara Cass of the Department of Public Health for their efforts to educate the medical community about this pressing need. I am sorry to say, though, that from the perspective of disability advocates, these educational efforts have fallen short of actually resulting in any meaningful action. We are very much hoping that today's session will be the beginning of concrete planning with actionable goals. In closing, I would like to quote Judy Heumann, the brave woman with a disability who was an organizer of the advocacy movement that resulted in the passage of the Americans with Disability Act. We recently lost Ms. Heumann, but her words live on. Quote, "The truth is, the status quo loves to say no. It is the easiest thing in the world to say no, especially in the world of business and finance. But for the first time, we were discussing civil rights, and no other civil rights issue has ever been questioned because of the cost," unquote. CCEA advocates would submit to you that it costs even more in the long run if we fail to provide equitable preventative health care to people with disabilities. And you will now be hearing from Dr. Lisa Iazzoni, a prominent medical researcher who is a professor at Harvard Medical School and director of the Morgan Institute for Health Policy at Massachusetts General Hospital. And we are very grateful to Dr. Iazzoni for her participation.
Hello, thank you so much for having me here. Are you able to hear me? Yes.
Yes.
Nodding? Okay, great. For almost 25 years, I've investigated healthcare disparities for adults with disabilities, concentrating on primary care, reproductive care, and cancer care. I also identify as a person with a disability. I have had multiple sclerosis for 47 years, and I've used a wheelchair since 1988. From 2012 to 2013, I had the honor of chairing the U.S. Access Board's Medical Diagnostic Equipment Accessibility Standards Advisory Committee, representing the Boston Center for Independent Living. This advisory committee was created pursuant to Section 4203 of the Affordable Care Act, which required the U.S. Access Board with the FDA to develop accessibility standards for 5 types of medical diagnostic equipment: exam tables, weight scales, stretchers or gurneys, mammography equipment, and other diagnostic imaging equipment. These standards underwent public comment through the federal rulemaking process, with final rules published in the Federal Register on January 9, 2017. To take effect February 9, 2017. On December 26, 2017, Trump administration announced that they were not going to pursue rulemaking about requirements for accessible medical diagnostic equipment in healthcare settings. However, just last week, nearly 6 years later, on September 7, 2023, Department of Health and Human Services Secretary Javier Becerra announced proposed rulemaking that would increase access for disabled people throughout the healthcare delivery system and other settings. It also addressed accessible medical diagnostic equipment. DHHS is accepting public comments on these proposed rules for 2 months. Accessible medical diagnostic equipment is personal for me. Shortly after one of my younger sisters was diagnosed with breast cancer in her early 50s, I scheduled a routine checkup with my new primary care physician. It's hard in Boston to find PCPs, and I was so relieved to have this new physician that I let my guard down, and I didn't visit the practice beforehand. After hearing about my sister's recent cancer diagnosis, my new PCP said she optimally would do a complete breast exam with me supine on the exam table. But her exam room was small. Getting me and my wheelchair into the room dominated by its fixed height, inaccessible exam table would be tight. As the appointment time was running short, the PCP did a cursory breast exam with me seated in my wheelchair. In more than 300 interviews that I have conducted over the last 25 years, with people with all types of disabilities, the stories really hit home with me. Women never get Pap tests because they're not taken out of their wheelchairs to do so. People do not get mammography because there isn't accessible mammography equipment. I interviewed 22 women who had used wheelchairs when they were pregnant. None of the 22 women were weighed during their prenatal visits because their obstetricians didn't have accessible weight scales. Many were not even gotten out of their wheelchairs for complete exams. Diagnoses of cancer were delayed, so cancer was diagnosed at later, less treatable stages. In one instance, a doctor lifted a woman with early stage breast cancer who needed chemotherapy out of her wheelchair and held her in his arms while he stepped onto a weight scale to get her weight, which was needed for setting the chemotherapy dose. Even though it was a big clinic, they didn't have a roll-on weight scale. Pressure ulcers were missed because exams of skin integrity were not performed, And these stories just scratch the surface of all the quality problems that I've heard over the years. You need two things for making policy, I think, stories, but also some numbers. And so let me give you a few brief numbers. This is from a 2019 to 2020 national survey of physicians that I was privileged to lead, and that was funded by NIH. Only 23% of physicians seeing people with major mobility problems always or usually use roll-on weight scales, 23%. Instead, 32% always or usually, and 40% sometimes simply ask the patients their weights. There's research out there that shows that those of us who use wheelchairs really underestimate our weights. So weights are not accurate. All you do is ask the patient. 40% of physicians only use height adjustable exam tables. This was higher for specialists, about 47% of them did, but only a third of primary care physicians. Now, I talk about disability a lot, and when I do, I always say it's a win-win-win for having accessible medical diagnostic equipment. First of all, it's a win for patients because they can more safely and easily transfer onto that equipment. Number two, it's a win for clinicians because doctors and advanced practice practitioners come at all different heights themselves. And so if they have a height adjustable exam table, they can adjust the exam table that is ergonomically best for them so that they can do a good exam on their patients. And then finally, it's a win for practice staff who are people who have the second highest rate of occupational injuries across all occupations because of transferring patients. Shoulder injuries, sometimes career-ending injuries. So equipment might have higher upfront costs, but this must be viewed in the context of the costs of staff injuries and staff absences because of those injuries and those turnovers. In addition, one final number from the survey, 71% of physicians did not know the correct way to determine reasonable accommodations for their patients. And so that's pretty troubling 30 or so years after the Americans with Disabilities Act was passed. And let me just point out that here in 2023, it's actually 50 years since Section 504 of the 1973 Rehabilitation Act was passed, which covers federal funded programs such as Medicaid and Medicare. And so here we are a half century later, and many of us still do not have accessible medical diagnostic equipment. I'll end my comments there, and thank you for what you're doing here today.
Thank you so much. This is very helpful. We appreciate your insight and sharing this with us. The next person on our list is Dr. Cindy Miller. Dr. Miller, you're on. It was on before. Yeah.
I am very pleased to share some of my story today. I am very pleased to share some of my story today in the hope that elements of it will strike a chord for legislators poised to advocate for change in the experience of people with disabilities as they seek medical care, which is as thorough as that of their non-disabled colleagues. While there are numerous issues worthy of consideration with designing a model for healthcare, which is respectful of and inclusive to those with disabilities, I will focus primarily on the provision of accessible medical diagnostic. Furthermore, I will propose a means by which the use of such equipment can be facilitated. I will not be citing numbers of people affected by disability or numbers who are not receiving the care that they deserve. Instead, I bring to the discussion my own lived experience as a person with a disability, including observations made in 2 different careers. I practiced diagnostic radiology in 2 academic medical centers over a period of 27 years, during which time I honed my ability to teach medical students and residents. In the course of an appointment with my own internist about 10 years ago, he asked if I'd be interested in teaching with him in a session for second-year medical students who were about to go onto the wards where they'd be interacting with patients for the first time. This was to be the only formal education they would receive about caring for patients with disabilities. I was enthusiastic about this opportunity as I knew I had a story to tell, and I thought I'd be able to convey my experiences in a way that was entertaining yet instructive. I must admit, though, that I was not sure that the students would necessarily be interested or even present, as attendance in class was not mandatory. In its first iteration, the session consisted of my internist and I sitting in the front of an auditorium completely filled with attentive students. My internist posed questions to me, which I answered with illustrative vignettes. When given the opportunity to ask their own questions, it was clear that the students' minds had been awakened to issues which they had not previously considered. It was also clear that a single didactic session on disability would not be adequate to answer all of the questions which had arisen. Although I retired from medical practice 6 years ago, I've continued to participate in this introduction to quote unquote, dealing with patients with disability and chronic illness. After retirement, I pursued a master's in social work with a concentration in advocacy about issues related to social justice. Certainly, the inability of a substantial portion of our population to receive a complete medical exam falls squarely into this wheelhouse. And now I'll share part of my own medical story in order to illustrate some realities of the current situation where adequate care is not being provided to all. Just over 65 years ago, the delivering obstetrician described me as being a floppy baby, a term given to infants who lack muscle tone. As is often the case, it was determined quickly what diagnoses I did not have. It took nearly 4 decades to figure out the all-encompassing diagnosis. This only occurred after new symptoms, seizures, prompted imaging of my brain with surprising findings that prompted input from numerous radiologists and neurologists in the United States before a consultation with a group in Paris who ultimately provided the correct diagnosis of congenital muscular dystrophy with myrosin deficiency. Unfortunately, with a confirmed diagnosis came the knowledge that I would experience significant progression of weakness, rendering me non-ambulatory and in need of mobility. When I was a medical student, I might have read that description and thought to myself, wow, that's an interesting case. And very quickly, my mentors would have encouraged me to think, but she is not a case. She is a human being. I'm not sure that there would have been any discussion of the modifications which would be necessary in order to perform a routine physical exam. In all but a few medical student schools currently, there is little to no attention to addressing such modifications. So what sorts of omissions am I making reference to? I can't forget my visits to my internist over the last 20 years. At the beginning, I would arrive in his clinic in a motorized scooter. A nursing assistant would first ask me to step onto the scale. I know I lost my temper more than once when I explained that I wouldn't be using the scooter if I were able to rise unassisted and stand on the scale. I was then asked if I knew what I weighed. I did not, and so we stopped. We made no attempt to get a weight. Some years ago, I became aware that I had lost a significant amount of weight based on how my clothes fit. That year, when I was asked what I weighed, I replied I did not know, but I thought that it would be necessary to figure out a way to get an accurate weight. As there were only a few large scales in the entire clinic building, it was necessary to go to another floor where a simple chair had been placed on a scale and weighed, and then I was transferred to this chair, after which my weight was obtained by a simple subtraction. My weight that day was 76 pounds, down from 93. Clearly, it was dangerous not to have been able to get an accurate weight. The message being that my weight would need to be recorded at least annually. All patients experience the same frustration about the short time they are given for routine appointments. For those with disabilities and the inability to move with ease to an examining table, this often translates to their having an incomplete exam, particularly as physicians attempt to examine them while they remain in their wheelchairs. There are two possible ways in which this can be improved upon: height adjustable tables, which would require that the patient have some ability to transfer independently, and Hoyer lifts, for which staff knowledgeable in their operation must be available. Another solution, which could complement accessible equipment, would be a care extender, similar in some respects to a doula who assists a woman during pregnancy. As I close, I want to share some words which I read on the website of Hyde Park, the home of FDR, who spent much time during his pregnancy in a wheelchair. Hyde Park has intentionally given attention to FDR's disability. On its website are the following words: disability is not only a state of health, it is a social construct, an interaction between the features of a person's body and the social or environmental barriers he encounters. It is imperative that the barriers to obtaining a complete physical exam be broken down for those with disabilities. Thank you.
Thank you so much. Thank you. The next person on our list is Andrew Bate. Is Mr. Bate here? Okay. Yeah. Mr. Bate, you can stay right at that table and we'll adjust that for you.
Maybe. What's that? Did you lean forward a little bit? Yeah, a little bit. There you go. Try and speak and see if it's good enough. Can everybody hear me? Okay. Good afternoon, Senator Anwar and members of the Public Health and Human Services Committee. And thank you all for your time, by the way. Let's see. Thank you for the opportunity to speak about accessible diagnostic medical equipment. I was a social worker that worked primarily with individuals that had various disabilities, and I myself have a disability. In 2003, As an employee of the University of Connecticut Health Center, I had the opportunity to speak with a group of medical students who had a specific interest in cerebral palsy, the condition that I live with. These were some of the brightest men and women I have ever had the opportunity to come in contact with. Just recently, within the last year or so, another group of medical students from the Disabilities Interest Group at UConn informed me that while an examination can be done in a wheelchair, can be done in a person's wheelchair, it is nowhere near as effective as actually getting up on an examination table and allowing medical professionals or other qualified professionals to do an examination. I was informed that laying down and having these dedicated professionals palpate certain areas was critical in assessing health and identifying certain conditions before they became either difficult to treat or not treatable. This information took me back a bit, as I have not actually been on an examination table for about the last 20 years. Since the age of 30, I am unable to transfer to any diagnostic medical equipment unassisted. I have attempted to transfer on the medical equipment. Oh, I've tried, but those attempts were not well received. For example, and I needed an X-ray of my stomach, and I managed to get about three quarters of the way to the X-ray machine before a technician informed me that I would have to walk the rest of the way. I attempted to do so with a walker and unsteadily made my way to the table. I forced my legs into the appropriate position on the table. The X-ray was taken, and immediately afterwards, I heard the words, "Looks good. Let's get him out of here." This was said in such a way as to indicate that I was a liability to the staff. So it wasn't in an effort to provide good customer service or fast service. Let's see. They indicated that if I needed any further X-rays, then I would need to do it at a hospital. No mention of any equipment, such as a wire lift, that might make the experience better for all. No guidance given as to how to request an outpatient X-ray at a hospital. Despite the Americans with Disabilities Act of 1990, which requires auxiliary aids to be provided so that individuals with disabilities may access services. The message that I received was very clear, and it was, you cannot get an X-ray here in the future. We will not help you, and it is not our problem. It is yours and yours alone. I have no doubt today you'll hear from many individuals about what is not possible. For example, providing assistance to individuals with disabilities takes too much time and is undercompensated. I believe that a rational approach to this issue starts in the area of primary care. At a minimum, my apologies, at a minimum, in my opinion, it is possible for large group practices and other facilities primarily engaged in the practice of providing diagnostic and or treatment services to have the equipment available, to have the equipment necessary and staff trained in order to ensure that individuals with disabilities receive a full examination and an accurate weight be established and reevaluated. For the record, I've not been weighed since I was under the age of 21 outside of an inpatient setting. In my vision for the future, this would be an interim step on the way to ensuring that machines like MRI scanners are accessible to all and delays in care are eliminated. As a social worker, I can definitively state that while I'm not aware of anybody that has died as a result of not having access to accessible diagnostic medical equipment, I am aware of close calls where people could not access appropriate diagnostic equipment, and as a result, treatment was delayed and recovery much more complicated. I heard discussions around a 5-year plan being developed and implemented to resolve this issue. In my experience, a 5-year plan can easily turn into a 25-year plan, well written, but sitting on a shelf without strong leadership and a determination by all parties to accomplish the final goal. To accomplish the final goal. I would be dishonest if I'd be dishonest to the legislators and all citizens of Connecticut if I said this was not a concern of mine. I hope that this forum is followed up by a planning process that includes individuals with disabilities and results in actions, legislative or others, that will lead to the mitigation of this issue. I thank you once again for your time, and if there are any questions, I will attempt to answer them. Thank you.
Thank you so much for your testimony. Thank you. We really appreciate your words, and this is very helpful to us. Next person on our list is Valerie Rump.
Thank you.
Hello, ladies and gentlemen of the committee. My name is Valerie Ann Rump. I'm a member of CC equals A. I live in New Horizons Village in Unionville. I do have plenty of personal bad stories with the medical system here, especially when it comes to diagnostic equipment and getting proper exams, or better way of saying it, lack of proper exams. One of the things that comes to mind is my weight. As you could probably tell, I'm overweight, but I honestly don't know my exact weight because I really haven't been able to get onto a scale that's wheelchair accessible. So the last time that I went to my doctor's office at the beginning of the month, we kind of had to basically make up some number, which is not a good thing, if you know what I mean. And also I've had issues in the past of trying to get a mammogram, and also I'm having issues with my hip joints and I am not looking forward to have to get an x-ray for that. I've also had a recent eye doctor appointment, and the building that I went to, I had to use my walker in there because the hallways were so narrow that I would not have been able to maneuver in there with my power wheelchair. And fortunately for me, I went with a family member so they could see what issues I was facing as a woman with a physical disability. I have cerebral palsy. I've had it for 53 years and it's never going away. And I just wish that there was accessible medical equipment that would make my doctor's visits easier and more efficient, so that they could catch things earlier and at a stage when they're cheaper to treat and easier to treat, rather than catching them at a later stage where not only is it more expensive to treat, but it's more involved for both the doctors and the patients. Other than that, that's really all I have to say. Thank you for your time.
Thank you. Thank you for being here. Thank you for your testimony. It really helps us understanding and sharing your experience. Next person on our list is Mary Beth Bruder. Mary Beth, there's a chair on that side.
Is this on? Okay. Thank you, committee members and Dr. Anwar, for putting this forum together. It's been a long time coming, and we personally thank Representative D'Amico for being our advocate extraordinaire. My name is Mary Beth Bruder, and I'm a professor at the School of Medicine at UConn Health. Let me try and do this. Thank you. I have been in the field of disabilities since I graduated college, which was in 1976. I have been at UConn Health Center since 1986. I currently direct the A.J. Papanico Center on Disabilities. It's a center for excellence in developmental disabilities, education, research, and service. And there are 67 such centers around the country. We have the task of being able to develop and translate research into services and practice. Advocacy, capacity building, and knowledge generation are the core tenets of what we do around the country. I'm here to just provide some specific data beyond the wonderful testimony you're going to hear today. Since the early 90s, my center and my staff, and mainly students, graduate students, interdisciplinary graduate students, both, okay. Okay. Have been invested in creating opportunities to learn about what is so we can make it better. So I'm here primarily to talk about three things today, very briefly. One is to provide some Connecticut specific data, first on the needs of people with disabilities through surveys that we have done. Two, to talk about the needs of physician and healthcare workers in regard to awareness, knowledge, and skill building to be able to serve people with disabilities across the lifespan. And third, most importantly, I hope that you will choose as a result of today to demonstrate the leadership that we need right now to create quality, inclusive, community-based healthcare for all citizens with disabilities. Our focus at the center is improving quality of life. I think you've heard and will hear, and it's not hard to think about the fact that quality of life is determined by the healthcare we receive from the time we're born. And I don't have time today to talk about it, but I also ask you to think about those who have intersections of disability with other disparities, such as race, language, and ethnicity. And that is an area that is also well overdue for us to take a look at how to create a better healthcare system. First, we have done a most recent survey in 2023, following up about 6 surveys since 1993 of families of children with disabilities all the way to people with disabilities. There is no difference, unfortunately, in what we found. Our last survey, which was done by graduate students, interdisciplinary graduate students, our center is interdisciplinary, primarily went out via a Survey Monkey. We had 78 folks who responded of all different types of disabilities. And 41% of the sample reported problems being able to use medical diagnostic equipment because of their disability. 50% of these people did have used a medical mobility device that prohibited them having physical access to buildings where they might have had medical equipment that they could use, but they couldn't even get into the building. I'm not going to read all of this, and I can make these papers available to you because we have the whole results set up. But just to give you the bullets, 41% of the sample reported problems with communicating to their healthcare providers, both in making their needs known and also in understanding what the healthcare provider were telling them, because again, sometimes it is a very fast visit. 39% said that they felt that the healthcare providers they saw had a negative attitude towards them and their disabilities. And a majority felt that their healthcare providers, even though they had been seeing them in some instances for many years, did not have enough knowledge about treating not just their disabilities, but disabilities in general. I think this really did point out to us, again, over 30 years, we're still having accessible problems. The positive thing is that 65% felt that their healthcare providers would participate in training and they would help do the training, which is obviously who should be doing some training. Okay, my second area of data around physician and other healthcare providers' needs. We again have done 8 different surveys to different types of physicians in different settings, from pediatrics to ED or emergency departments, to specific physicians who are involved in the transition to pediatric to home care. We've also asked about specific disabilities such as autism. So, for example, without going through all of these, in 2019, 91 healthcare doctors who were general practitioners, family medicine, and internal medicine physicians, most reported seeing people with disabilities in their primary care. However, less than half, 41%, felt that they were knowledgeable about how to provide that care. More than half reported professional experience as actually it was 60%, as the only way they learned about disability. And most reported wanting additional training. Most recently, in 2019, also, we worked with emergency departments. I have a nephew with severe intellectual and physical disabilities. Every time he needs to go into an ED, it's not a good picture. And this is reinforced by our own Connecticut data. 7% of ED staff reported that they were knowledgeable about those with intellectual and developmental disabilities, especially if they had co-occurring conditions. Only 30% felt that they were knowledgeable about people with autism, including young children. So we asked participants if they'd ever received training, and 46 reported that they had received some type of training. This goes on. We also just surveyed our local health departments to ask about knowledge about disability. And out of a number that came back, 25 local health departments, Over half would like training on access for services for those with those with disability and knowledge about caring for people with disabilities. So that's, again, Connecticut data. I think that we do know better, so we should do better. There are national curriculums out there. There are national curriculums through a number of different physician advocacy organizations and the Association for Universities with Centers for Disabilities. We at UConn have provided training to pediatric residents, to medical students, and to those who are in the community. The issue, again, unfortunately, tends to be both regulation and funding. And this is something that I think the legislature can look into in regard to some states that are requiring more training for their healthcare providers. We need to be there. So lastly, as you heard about the HHS reissuing on the 50th anniversary of 504 rules, a new look at the rules, and in particular, they are emphasizing people with disabilities need to have access to medical equipment, communication strategies, and compliance to the 2010 standards for accessible design issued by the Department of Justice. I would love for Connecticut to take the lead and to really demonstrate that we can be a leader in healthcare access for people with disabilities. It's more than time. And I thank you very much for your listening.
Thank you so much. Thank you. We will take the Q&A towards the end of our conversation. So because there are a number of other speakers and we want to try and make sure everybody has the opportunity to share their perspective. And the next is the Connecticut Association of the Deaf. We have the president of the association with Louisa Gasco Soboleski. You're on. Welcome. The mic.
No. Hello, and thank you. Good afternoon. I, Louisa Gasco Soboleski, am here to present on behalf of deaf, hard of hearing, and deaf-blind people, the Connecticut Association of the Deaf, and the Board of Persons for, the Advocacy Board for Persons who are deaf, blind, and hard of hearing. I am also a retired principal of the American School for the Deaf and a third-generation deaf person. Thank you for giving us the opportunity to come before you today on this very important topic and allowing accessible care for people who are deaf, blind, and hard of hearing, and to ensure better services for our community, especially in the area of healthcare for persons with disabilities. As an educator, I strongly believe that working together will help us to improve services, especially when we have experienced with what we have experienced with the pandemic recently. In working with the deaf community, they have often expressed frustration that they have faced during the pandemic in the area of communication. Accessibility was not well received by most of our community members. And to clarify, 90% of deaf people have some amount of hearing. Have hearing parents. So 90% of deaf people have parents who can hear. And therefore 10% of deaf people have deaf parents and therefore have language access from day one, unlike people who have hearing parents. And so there are very few people who have access. Those who do not have deaf parents, their access to communication starts much later. And it tends to be sometime between the age of 0 to 5, their acquisition of language is critical, and that leads to what's called language deprivation. It is important that proper communication access is given to every child as soon as possible. Looking back in history briefly, Connecticut was the first state to have a commission on the deaf and hearing impaired. And in 2011, unit merged with DOORS and then closed in 2016. Our unit had a community liaison who offered training to medical providers and also to police and fire departments. And since 2016, there has been no such training available, which has caused a number of issues to come up more and more often. The issues that we are seeing in the hospitals and in the healthcare field continue to use video remote interpreting, that is by using a video phone, and has caused problems and difficulties for a number of deaf and hard of hearing and deaf-blind people who cannot use that equipment, or that the Wi-Fi is insufficient to allow for a picture smooth enough to understand the motion of sign language. Oftentimes, those interpreters who come up on a video screen are not from Connecticut, and so are unfamiliar with agencies and town names that are within the conversation. The hospitals here in Connecticut have contracted with only one sign language interpreting agency provider. And we will often see deaf consumers not receiving interpreting services because there's no one available. It has been a life and death situation for our community, and more than one provider that I've used in the past before 2016. There had been only 2 providers who worked in the healthcare industry. This has been an ongoing difficulty for deaf-blind, and the hard of hearing community. It's been a source of frustration, and I receive numerous calls from people in the community expressing their difficulties and concern, lack of care. We absolutely need to improve this situation. I'm sure that you've read the Connecticut statewide needs assessment report. And this is something that we need to address and improve within our state. We need your support. And of course, we will work along with you to make this state a wonderful place for deaf, blind, and hard of hearing citizens, which is long overdue to our community and needs to be recognized and heard. Thank you.
Thank you. The next person is Dr. Harvey Corson, Chair of Education and Legislative Committee.
Hello, good afternoon. My name is Dr. Harvey Corson, and I am Chair of the Education and Legislative Committee of the Connecticut Association of the Deaf. I want to thank all of you for the opportunity to speak today on this topic, focusing on people who are deaf, deaf-blind, and hard of hearing. This matter is extremely important and timely, especially considering our recent experience that we had with the COVID-19 pandemic. Experience is life's greatest teacher if we are willing to learn from the journey. If not, we unfortunately would be doomed to repeat these same needless errors again the next time. There's much we can learn from sharing our experiences with each other. We have seen many heroes doing valiant work throughout the pandemic, learning from their struggles, learning on the spot as they went through the pandemic. They had to fight against the unknown and learn from it. Evidently, although in these modern times we are intelligent human beings, we need to learn from our experiences so we don't have to go through this again if there's another pandemic or something equivalent. During the fiscal year 2021 to 2022, Governor Lamont recognized the difficulties experienced by thousands of people in this state. He went on and remarked that the deaf community was hit particularly hard during the pandemic. The governor was recommending $2 million in the American Rescue Plan Act, ARPA, requested that funding for over 2 years to address deficiencies in support services for individuals in the deaf community at large and specifically at the American School for the Deaf. These investments would include operational supports for COVID-19 expenses, such as clear masks, vaccine informational videos, interpreting support at vaccine clinics, etc. While these address some specific issues that individuals had, many people were still struggling to navigate the system. There were other resources that were developed for the people of Connecticut, including community education and toolkits, especially for Black, Indigenous, and people of color and faith communities. However, the large majority of these resources did not plan for communication accessibility for the deaf, deafblind, and hard of hearing communities. Furthermore, gaps in COVID-19 related resources, information, and services were noted. And it highlighted the lack of knowledge that the broader community has for our language and culture of the deaf, deafblind, and hard of hearing communities. And these deficiencies would be attempted to be addressed by deaf community leaders through providing self-advocacy workshops for this population specifically. We had some recent research that was published that was called the Connecticut Statewide Needs Assessment. That report was published and it looked at the years of 2016 to 2023, and that was done by Innovi Strategies. And the funding from ARPA is what made this research possible. And it identified our most pressing needs for our deaf, deafblind, and hard of hearing community. And these needs were based on feedback that was collected from 101 participants from 8 different focus groups that were conducted here in the state. And there were several key recommendations, but I would like to mention just 2 today. One noted communication barriers significantly limit deaf signers' access to healthcare services and exacerbate the disparate healthcare outcomes. The second one I would like to highlight is the deaf community has expressed a significant need for a government level office or department that specializes in deaf services. And now I would like to just share a few examples of incidents that have occurred to help illuminate these points. So the first example I'll share is something that happened in a hospital. A deafblind individual had requested interpreting services, and they were provided that through video remote interpreting services. And the deafblind individual was not able to physically see the screen that the interpreter was on, thus not being able to have equal access and not being able to have the services done that day. As well, during COVID, or even generally, many doctors and nurses wear masks, which we understand are medically necessary. But for our community, specifically the hard of hearing folks in our community who rely on lip reading, this excluded them from having access to communication as well. So because their ability to, the masks covered people's lips, so they were not able to read their lips anymore. And many folks did not utilize clear masks as well, which would have allowed some of the community to have access. There were many announcements that were made about the pandemic on TV, which was great. And we understand it's essential, but they were not accessible for many of the deaf, deafblind, and hard of hearing individuals in the state, as there was no captioning on TV, nor was there a sign language interpreter provided. Another example, there were many elderly persons who were placed in nursing homes without any sign language support and were essentially isolated as a result. They were not able to use or benefit from the magic that we know now of FaceTime or a video phone. Some deaf friends would try to help them communicate. They would go and converse with them, communicate with them through sign language, but they would have to do so from the outside through a window just to help relieve them from their isolation. And this occurred during winter months as well. And that created some weather-related issues because they were stuck outside, standing there trying to help, signing through the window. The solution arrived when the healthcare system finally announced that a second person, a relative or a friend, for example, even a sign language interpreter, might be finally allowed to accompany this elderly person to the hospital, emergency department, or nursing home. Healthcare professionals learned from these experiences. As for deaf, deafblind, and hard of hearing individuals, they have had to go through these similar types of incidents again and again and again throughout their lives. So these encounters were only heightened or intensified during the pandemic, but they were encounters that they've encountered their entire life. And we can incorporate these life lessons systematically into appropriate orientation or training programs that train new healthcare workers who will be coming in to replace the older generation who is retiring or those who have transferred to other jobs or locations, or those who might be out sick. For deaf, deafblind, and hard of hearing persons, communication access is a serious matter and is truly life or death, a life or death matter in some healthcare situations. I believe in a team approach and working together to develop workable solutions to address these communication access issues or concerns. It is also recognized that we have a shrinking pool of available interpreters, and we may need to join forces on a state level so that we're able to address this issue in terms of making different training programs that might be available for interpreters to work with the deaf, deafblind, and hard of hearing community. And we might need to be innovative in how we provide this program and maybe even offer incentives so that we're able to attract more people to work in this workforce. And such an important area of working in health services. Thank you so much.
Thank you so much, Dr. Carson. The next person on our list is from the Connecticut State Medical Society, Dr. Robert Russo. Dr. Russo is online. Dr. Russo, you're on.
Thank you very much. First, I want to say thank you to Senator Anwar and Senator Lesser and the state representatives, McCarthy-Venier and Gilchrist. I'm Dr. Bob Russo. I represent the State Medical Society, which also represents about 4,000 physicians in our membership. This issue is massively important to physicians. The patient-physician relationship over the years is really the bedrock of what we stand for. As you know, it's taken the federal government years to catch up and talk about standards, particularly for medical equipment. Over the next couple of months, the input should finish, and we should have maybe nationwide standards for what the equipment should be able to do. To give you a little bit of an example, however, let's look at MRIs. MRIs come in 4 different types: stand-up, open, low field, and high field units. Now, for most patients, that's not a real challenge. However, for handicapped, disabled, blind, or hard of hearing patients, it's very difficult. The stand-up unit, you have to be able to stand up. For the open unit, we use that for patients that can't lie flat sometimes, or may have a limb that is distorted that won't fit into the smaller bore. And for the high field units, again, the bores change. What's important in the high field unit is the weight. We really need to know the weight of the patient, not only for the material contrast that's given to the patients, but whether the table will handle the weight. So when we look at that and you're going to set standards, it's the manufacturer that's got to change. It isn't going to be the state of Connecticut making standards. It's going to be a national standard that the manufacturers are basically going to be forced into. One-offs or 50 separate state regs probably aren't going to sell well to the manufacturers, but I do think it's possible to get it done. What is another major problem, however, for things like MRI is in the software side, the scheduling side. As you know, our world is shifting from private practice into the bigger group practices where scheduling now is centralized. We get fairly good information from the physicians in the pre-authorization process, but what we really need is to modify the scheduling. We need particular formulas for asking the patient and the patient's caregivers what the handicap or the disability is and what the patient is capable of doing. So in the algorithms of scheduling, we need to be able to separate patients that need additional care. And the insurance companies need to recognize that as an add-on. You can't do most handicap or disabled patients in the same amount of time as you can a walk-in type patient. What we need to know is, do they know their weight? Can they get out of a wheelchair? Can they lie flat? There's a lot of patients that lie flat and get dizzy because they get hypotensive. Or when they stand up, they get hypotensive and faint. We need to know who's coming with the patient. Do they have a caregiver that they don't feel secure without? A caregiver can't have a cardiac pacemaker. The patient can't have a cardiac pacemaker. The patient can't wear a hearing aid in an MR magnet. The caregiver that's going to be near that patient can't wear it. We need all of that information. So the anecdotal stories that you're hearing about people being refused at the scanner because there's something that the office didn't know before the patient came, we need to eliminate that. If the patient needs to be weighed in an unusual fashion, perhaps the patient would stop in an ER or another facility first before coming. Perhaps we need prep rooms. And a lot of MR systems now do, like surgery. You have a prep area. where you can get the patient out of their wheelchair onto the proper stretcher. Remember, the stretchers for MR are non-magnetic. They cost tens of thousands of dollars. You have to have a particular stretcher that the patient can be lifted onto and lift off of. You can't do that in the room. One of the earlier speakers talked about mammography and trying to get in a cramped quarters out of a chair to the machine. Those machines can easily be modified to come down to a certain level. You can also take patients out of their wheelchair and put them in a different wheelchair where the sides collapse and the equipment can be moved into the proper position. So what we're hoping for is that the federal government will solve the manufacturing problem by asking them to be redesigned to be able to handle the handicap. What we need is for the software and the chart people to change the scheduling system so there aren't surprises at the front desk of an MRI facility or another diagnostic. The other problem that's kind of come up that I think we need to talk about is if we look in Connecticut, as the private practices are beginning to fade, you're seeing physicians leave private practice to go into the bigger groups. If we now go back to the private practice groups, perhaps the 2 or 3 physician groups that are in 1,500 to 2,000 square feet of office space, and now say every exam room has to be handicap accessible, or every corridor has to be so wide, all these other things that are necessary, rather than say the proportion of their patient population perhaps is 10 or 20%. If 1 or 2 rooms would be available, it'd work. If not, they're going to have to move. And for a small practice, moving to handle those sort of new regulations would be a burden that is going to make them not do it, but join the bigger groups. Now, there's not a quality of care difference between the 2 groups, but there is a physician-patient relationship in private practice that particularly people with disabilities and handicaps develop one-on-one relationships with their physician. That's a very important relationship to people that are handicapped. We don't want to lose that if we don't have to. So if we're going to make regulations about how an office is going to be redesigned, we have to be careful that we don't force, for financial reasons, the doctors into the bigger systems, because you might lose that patient-physician relationship that's so important, where the doctor understands handicaps and disabilities, where the bigger systems, patients sometimes can get lost. We need both. We need the ability in the larger systems to do all the sophisticated work, but you can't forget about the primary care physicians that are in the smaller practices that need to survive in this sort of environment. So I think those are today, at least, our biggest issues. Force the manufacturers to come up with a national standard and force the software companies to give us more information up front so we don't have this problem of patients showing up that cannot be cared for in the proper way in the proper facility. Thank you for your attention.
Thank you so much, Dr. Russo, for your insight. We will have some questions at a later time in our conversation. The next is a group with the Connecticut Hospital Association. We wanted to thank you, Karen Buckley. We'll get all the people together. Karen Buckley, who's the Vice President for Advocacy, Brian Cornoyer, who's the Director of Government Relations, and Jennifer Cox, who's the outside counsel. Welcome.
Thank you. Good afternoon. As you've heard, I'm Karen Buckley. I'm the Vice President of Advocacy at CHA. I'm joined by Brian Knoyer, and online we have Jennifer Cox, who's the outside counsel for CHA. And we very much appreciate the opportunity to talk with you today about this important topic. CHA has been fortunate to be given the opportunity to participate in the multi-stakeholder advocate-led group that is focused on increasing access to healthcare services for persons with disabilities. Our time with this task force has been informative and instructive, and this advocate-driven group meets monthly with a focus on improving access to care generally and through the deployment of accessible medical diagnostic equipment, or we call it MDE. MDE includes, as you've heard before tonight, earlier today, equipment such as examination tables, examination chairs, weight scales, mammography equipment, X-ray imaging, and other radiological diagnostic equipment. As you've heard, there are federal guidelines for MDE, but those guidelines first created in 2011 by the Access Board, the entity discussed earlier by Dr. Iazoni, I'm not sure if I'm saying her name correctly, are currently advisory only on the national level. Just last week, new and updated federal regulations were announced that will revolutionize the healthcare continuums framework for access to care for persons with disabilities on a nationwide scale. The newly published rulemaking is over 400 pages long and covers a breadth of topics, including medical decision-making and medical ethics, organ transplant, online and web-based applications, a comprehensive plan for moving forward at the federal level with access to medical equipment, both diagnostic and treatment. While there are many details that need to be addressed before the federal rules become law, these changes will bring about the most significant and sweeping shifts in improving medical access for persons with disabilities in decades. These changes will touch every aspect of the medical system, including ethics, building codes, manufacturing requirements, graduate medical education, and ADA compliance. These changes are appropriately addressed at the federal level in a comprehensive manner. There really is no realistic way to comprehensively address these issues on a state-by-state basis, but Connecticut can better prepare to make a smooth transition to these new federal level rules. Connecticut has already taken a step towards readiness in anticipation of the change in federal equipment regulations. Under Public Act 22-58, Section 73, it directed healthcare institutions to consider accessible medical diagnostic equipment that could meet current advisory level guidance when buying new equipment. What that means is every time someone is buying new equipment, they have to consider the advisory guidelines. This will promote better understanding, better uptake, and better overall adoption in Connecticut sooner than in other states. We will be ready when the federal guidance is made final to implement this. This approach also recognizes that until manufacturers are required by federal law to make these types of equipment universally, the cost of switching to a customized, limited supply of medical diagnostic equipment is unrealistic and cost prohibitive. The medical diagnostic equipment rules are quite technical, functioning much like a building code or a fire code. To foster better understanding and increase adoption of the federal guidance as soon as practical, in October of 2022, in conjunction with its work of the MDE work group that you've heard from many members today, CHA and the Medical Society hosted an important educational forum for hospitals and other providers to learn the specifics about accessible MDE. The featured presenter was accessibility specialist Bobby Stinnett from the U.S. Access Board, the best and primary source for the information. The program was recorded and is available for providers and others who are interested in learning more about the MDE guidelines, and both CHA and the Medical Society shared that recording and that information broadly among our membership. CHA and its members are committed to taking the necessary steps to ensure a smooth transition when federal laws and rules are available. But we want to make it clear, providers will not be able to do this alone. The state will need to invest resources, financial and otherwise, to help providers meet the challenges laid out in the federal regulations. There will need to be a statewide recognition that compliance with the new federal regulations will be expensive and will increase the cost of delivering healthcare, at least initially in Connecticut. CHA looks forward to working with the legislature, the administration, and the relevant agencies to find solutions that move us forward quickly and smoothly. We are also committed to finding other means to increase access for persons with disabilities, including through education for providers and medical professionals, listening sessions, and improving provider understanding of the needs of persons with disabilities generally. and at the individual patient level, including improving communication throughout the continuum of care. We recognize that an all of the above approach is needed, which necessarily must combine the efforts and energies of advocates, members of the disability community, providers, agencies, and the legislature. We look forward to continuing this important work and to finding solutions that can be implemented to increase access to care. And we thank you for the opportunity to participate today.
Thank you so much. Thank you for your testimony and your insight. We'll move on to the next person. That's going to be from the Radiological Society of Connecticut, which is Carla Brathwaite. You're on. Welcome.
Thank you very much, and thank you for the opportunity to speak at today's forum. My name is Carla Brathwaite, and I am the manager of DEI programs and health equity programs at the American College of Radiology. And in addition to my role at the American College of Radiology, I serve as the team lead for the Radiology Health Equity Coalition, of which the American College of Radiology is a founding member. The Radiology Health Equity Coalition, often abbreviated as REC, stands as a beacon of hope and a catalyst for change in the field of medical imaging and radiology. Committed to the core principle that healthcare should be accessible, equitable, and compassionate for all, REC brings together a diverse and dedicated community of professionals, experts, advocates, and allies. With a shared vision of eliminating disparities in radiologic care, this coalition has embarked on an inspiring journey towards a more equitable healthcare landscape. Founded on the fundamental belief that everyone, regardless of their background, deserves the same level of high-quality care, REC is a driving force behind initiatives aimed at dismantling barriers to access and fostering inclusivity within radiology. By promoting awareness, education, and action, the coalition strives to ensure that no one is left behind in the quest for better health and well-being. Providing quality radiologic care to patients with disabilities requires a patient-centered approach, effective communication, and adaptations to accommodate their unique needs. Here are some key steps that the coalition is committed to take to ensure high-quality care for patients with disabilities. The first step is to ensure that radiologic teams receive training on how to interact with and provide care to patients with disabilities. Sensitivity training can help staff members better understand the challenges that patients face. Also, in terms of effective communication, we want to ensure that there is a start to the conversation by asking open-ended questions to understand the patient's specific needs and concerns. We also encourage radiologists to pay close attention to the patient's responses and concerns, and also show empathy and patience. We are also encouraging our members of the coalition to avoid medical jargon and use plain, easy to understand language when discussing procedures and results. And in terms of accessibility, we are working with radiology practices to ensure that their facilities and equipment is accessible. For example, ensuring that there are ramps, elevators, and accessible bathrooms in the facility. Also, we encourage radiology practices and departments to have adjustable examination tables and chairs to accommodate different mobility levels. We also want to build toolkits that relay steps to ensure equitable access to effective and quality radiologic care. And that includes offering sign language interpreters or communication boards for patients with hearing impairments. We want to make sure there are written materials that are available in accessible formats. And we also want to ensure that there is a level of patient comfort and dignity. And we also encourage our members to always respect the patient's privacy and dignity during the examination, offer extra time for positioning or transferring patients as needed, and provide gowns and drapes that are easy to put on and take off. And we also encourage our members of the coalition to clearly explain the procedures, its benefits and potential risks, and ensure that the patient understands and consents to the procedures, and as well as using accessible materials if necessary. We strongly recommend that there is a utilization of adaptive equipment such as positioning aids, wedges, or paddings to help maintain patient comfort and proper positioning during imaging. We want to ensure that there is an availability of clear instructions on how to prepare for the procedure and explain what to expect during the examination, including any sensations or noises. All of these steps, we want to work with our key stakeholders and members of the coalition to build educational resources, toolkits, training materials for patients, as well as providers. And we want to make sure that this effort is a collective effort. We recognize that the work that we're doing in reducing healthcare disparities in medical imaging is not in a vacuum, and we encourage all the stakeholders on this call to participate in the coalition and join our efforts. We seek to collaborate with other healthcare providers and specialists to ensure comprehensive care for patients with complex medical conditions. And by implementing these strategies and maintaining a patient-centered approach, medical imaging professionals can provide high-quality radiologic care to patients with disabilities, ensuring their safety, comfort, and satisfaction throughout the process. As we dive deeper into the realm of radiologic equity, we want you to join us in exploring the inspiring work of the Radiology Health Equity Coalition, its mission, and the transformative impact that we can make in the lives of individuals and communities. Together, we can achieve a future where healthcare knows no boundaries and radiologic excellence is truly accessible for all. And thank you very much for the opportunity to speak.
Thank you so much for your testimony. The next person on our list is Raisa Khalid. I wanted her to speak. Raisa is an intern who's been working with me. She's a high school student from South Windsor High School, and she's been working with many of the disability community advocates, and they actually requested that she speak. So that was from the request of the disability community who've been she's been working with for the past many weeks. So Raisa, you're on. You can turn that on. Perfect. Go for it.
Hello, I am Raisa Khalid, as Dr. Saud Anwar said, and I go to South Windsor High School, and I intern for Dr. Saud Anwar. I'd like to thank everyone for letting me be here today. Let me ask you all a question. Let's say you went to a medical center to get a special x-ray. It's crucial to determine your diagnosis, but the technician says, nope, can't do it. It might be good for you, but it's not convenient for me. How would you feel? Enraged, oppressed, marginalized? Sadly, this is the bitter truth of what happens to nearly 11% of Connecticut's population. Under Dr. Saud Anwar, I investigated the 29 hospitals in Connecticut, contacted medical professionals, and spoke with remarkable people with disabilities. It has all led me to one conclusion. We need to create policies for disability-friendly services in healthcare facilities and ensure appropriate medical diagnostic equipment. From my investigation, I created a website that has my findings and a map. The map displays all the hospitals in Connecticut. When you click a hospital location, it shows information about the disability accommodations the hospital claims to have. However, after interviewing people with disabilities, I found that the hospital's information can be misleading. In addition to interviewing people with disabilities, I also interviewed medical experts such as Dr. Peter Deckers, the former dean of UConn Health, and Dr. Mary Beth Bruder, a professor at UConn Health who works for the Center for Excellence in Developmental Disabilities. My findings from these interviews were absolutely astonishing. Jay Toulin was the caretaker of his late wife, Nancy, who was in a wheelchair with a disability and weight issues. Nancy went to the doctor's office, and the doctor said, "You can't get on my exam table. You'll break it." Rachel, a kind, sweet woman with cerebral palsy, never saw a wheelchair scale at any doctor's office, except for one, and they didn't use it. And she has never gotten a proper mammogram, except once, when there was a properly trained technician. She also told me that she can't remember the last time she was on an exam table. Suzanne, similarly, was given ultrasounds instead of mammograms due to her disability, which is not the right process for a breast examination. The imaging facility even told her, "We no longer take wheelchairs. If you can't walk in for the visit, we can't have you here." Jamie was never taken onto an examination table. His doctors told him that blood work tells you everything. This is not a fact. You can't check for sores or any crucial issues if your patient is not on a table. All these stories are just a drop of water in an ocean. They all highlight that whether it's mammograms, lifts, special scales to measure weights, there have been disadvantages and technical limitations for the disabled. Furthermore, almost everyone I interviewed claimed that there is not enough space for wheelchairs in doctors' offices. The medical professionals are not trained enough to accommodate people with disabilities, which, as Dr. Peter Deckers claims, greatly hampers access to medical diagnostic equipment. The problems span from structural, equipment, and training barriers. Before I leave the stand, I would like to express my gratitude to speak here for a cause that must be addressed. Please visit my website named Disability Friendly Services in Hospitals, or DFSH, where I posted a 10-minute video that explains and expands on this problem. And I'm grateful to be here today. Thank you all very much.
Thank you. Thank you so much, Raisa. You put your heart into this whole effort. We're very proud of you because you've put in hundreds of hours of interviews, conversations, and research. So thank you for your work. Next person on our list to speak is from the Connecticut Council on Developmental Disabilities, Walter Glom, Executive Director. You're on. Thank you so much for being here and welcome.
Thank you. Good afternoon, everyone. My name is Walter Glom. I am the Executive Director of the Connecticut Council on Developmental Disabilities. I'm also a parent of an adult who lives with developmental disabilities here in Connecticut. The Council is a division of state government that is entirely funded by the Federal Administration for Community Living for the purpose of helping Connecticut to improve its system of community-based services and supports that enable individuals with developmental disabilities to live in the home and community of their choice. This includes access to health care. The Federal Americans with Disabilities Act requires that healthcare entities provide full and equal access for people with disabilities. And as you heard, last week, the United States Department of Health and Human Services issued a new proposed rule to strengthen prohibitions against discrimination on the basis of disability in healthcare. I would note that the United States Attorney for the District of Columbia stands ready to enforce this new rule. I'm here to explain that physical access to medical diagnostic equipment is just one of many challenges faced by individuals with developmental disabilities in accessing healthcare. Now, developmental disabilities are lifelong impairments that result in substantial functional limitations in 3 or more areas of major life activity and require lifelong services and supports. Developmental disabilities may include intellectual disabilities, severe behaviors, autism, anxiety, schizophrenia, physical impairments, visual impairments, or hearing impairments. And please understand, developmental disabilities are not conditions to be fixed. Developmental disabilities are conditions to be accepted and accommodated in our communities. Access to primary care cannot be segregated or relegated to administrative or bureaucratic silos. You cannot and you must not require people to travel across the state of Connecticut to receive reasonable accommodations for basic primary health care. In 1981, the council received a grant from the Federal Center for Disease Control to improve access to the COVID-19 vaccine by people who live with developmental disabilities in Connecticut. Our primary concern was individuals with intellectual disabilities, severe behaviors, autism, and psychiatric disabilities. Through that work, we learned that many individuals had been denied necessary accommodations for vaccination at major healthcare providers. We would ask the individuals, how do you normally get your vaccines? And for many, the answer was, we don't. Thus, we began to learn that many people with developmental disabilities are not receiving essential primary care. In 1981, in collaboration with the town of Vernon, the council set up a special clinic to provide vaccinations to individuals with developmental disabilities, where we learned that many individuals with developmental disabilities require more intense communication with a provider prior to a visit, more time and space, a sensory-friendly environment, and in some cases, staff certified in physical maintenance techniques. Furthermore, as a parent of an individual with developmental disability and as the director of the council, I continue to see and hear about barriers to healthcare. Though our information is largely anecdotal, the national research by Dr. Iazzoni and her colleagues and surveys by Dr. Bruder at the University Center for Excellence in Developmental Disabilities here in Connecticut support our concerns that many individuals with developmental disabilities are not receiving necessary accommodations for essential primary care. Beginning next week, on September 19th, a week from today, the council will begin hosting a series of speakers to educate policymakers about healthcare challenges facing people with developmental disabilities. Most of you on the panel, I think, have already been invited. Everyone's welcome. If you would like information, please contact me. Through a series of 6 sessions bi-weekly, we will be sharing national research, local experiences, and initiatives from other states. And I'll note, just as Dr. Bruder did, our council is one of 56 in the country. There's a council in every state and territory in the US. So we have access to my colleagues in other states to tell us, how they're handling these issues. We're hoping that this program will begin a broader discussion about ways to provide necessary accommodations for essential primary care. Thank you.
Thank you so much. Thank you. We appreciate you being here. So for benefit of everyone, we had invited many of our state agency leaders to be able to listen in to our conversations today. The purpose was that as the legislators from the Human Services and the Public Health Committee, we are listening to the issues that you brought to us. We also wanted to make sure that there's an opportunity for our special departments for the state, the administration, with cognizance to this issue. So this is the time where we would have some of our state leaders with the various departments. If they want to make a brief statement, they're welcome to do so. I would start with the Department of Aging and Disability Services. Commissioner Porter was here earlier. Welcome, Commissioner. And anybody from your team, they're welcome as well. Thank you.
Thank you so much, and thank you for hosting this forum. It's such a critical issue. I am joined by 3 members of my leadership team, but I know we want to get to questions and answers, and so I'll just go briefly, and then if they'll be here if there are questions afterwards. So again, my name is Amy Porter. I'm Commissioner of the Department of Aging and Disability Services. This focus on equal access in healthcare is just so critical. As you've heard, it rolls in issues of independence, of dignity, of health outcomes. So we are not an agency that regulates providers. We don't pay for medical care, but as the Department of Aging and Disability Services, these are concerns we hear about all the time. And we want to make sure that we're partners as we're looking at equal access. So we are doing a few things that I thought I would share with you today. You heard Dr. Corson and Louisa talk about the ARPA dollars. We did partner with the American School for the Deaf and leadership in the deaf community to make sure that create the right kinds of questions to do the needs assessment that they talked about. We used that starting point to then expand the services and do some additional work with the American School for the Deaf to address some of what we learned during COVID. And they're right, we learned a lot. So the funding is there and available to the American School for the Deaf, and we're working in close partnership with them. We are working with the advisory board for persons who are deaf, hard of hearing, and deafblind to look at the legislative charge that we got last session to look at medical access specifically for individuals who are deaf, hard of hearing, and deafblind. And we're hoping to build on the work that Innovy's already done in the needs assessment and expand that to ask some additional questions to get to some additional folks and get perspectives that we can share back with you. And that's on the agenda for the advisory board meeting, which is next Friday morning for anyone who's interested. We're also active participants in both the Medical Diagnostic Equipment Task Force and the Wheelchair Repair Task Force. You've heard them mentioned today. And we have a human services advocate who has been collaborating with folks from the deaf community, with CHA on issues around deaf culture, access to interpreters. So we're trying to address some of these issues in the role that we can as sort of advocates and champions, and we are willing partners with all of you as we think about how to move forward and address these critical issues.
Thank you so much, Commissioner. Thank you. Thank you for your work. Next on our list is from the Department of Public Health, Dr. Jody Terranova and Barbara Cass. You're welcome. Thank you for joining us.
Thank you, Senator Anwar. Jody Terranova, I'm serving as Deputy Commissioner at the Department of Public Health, but I come as a background as a primary care pediatrician, so I know about many of these issues that we're discussing today firsthand. And I just wanted to say that regarding access to care, I saw this most prominently in my patients when they were navigating from the safety net of pediatric care and transitioning to the world of adult medicine and trying to navigate that. And we've heard today that there are clearly gaps for people with disabilities. And I just want to say that while not all pediatric practices are perfect, I think we should look at some of the things that pediatricians and pediatric offices and pediatric hospitals are doing right for children with disabilities and see how we can translate that to improving medical care for adults with disabilities. I really want to thank all of you who shared your stories today. As someone who is a medical educator training new physicians for almost 2 decades, it was really heartbreaking to hear the stories of substandard care that you received. And thank you for educating us. You deserve better, and I'm really grateful that this group is together to learn from all of you. And I really look forward to collaborating with our legislators and sister agencies to learn more about this issue and see how we can address it. I will turn it over now to my colleague, Barbara Cass, to just say a couple of words. Thank you.
Thank you, Senator Anwar, and thank you, Deputy Commissioner Terranova. I am the DPH representative to the, as Karen Buckley from CHA has phrased it, the MDE work group. And under Ruth Groby's guidance and leadership, we have very active and dynamic discussions, and with the overall arching goal of increasing awareness. Pursuant to Public Act 22-58, Commissioner Jitani does annually release a document notifying physicians, APRNs, physician assistants, and other practitioners of the need to provide quality of care, complying with accessibility standards that are currently in place. I also appreciated Dr. Bruder's comments and the survey findings, and that was telling me really, really strongly and reinforcing that what we're doing is not enough. We do need to communicate wider, broader to our practitioner community. And we have formed a subgroup within our MDE work group to look at this issue and what can we do better. We have had active conversations, and again, using Dr. Bruder's team, we are going to look towards developing a guidance document that we will release to Practitioner and Provider Association. Currently, the document that Commissioner Jitani is releasing is specifically going to that cohort, physicians, APRNs, PAs, and healthcare facilities. But we would like to look at releasing it much more broadly. And this is really mission critical to the work that we are doing right now. So thank you.
Thank you so much. Thank you for your work. Next on our list is from Department of Social Services. We have Commissioner Andrea Barton-Reeves and Donna Belaski.
Thank you, Senator. Dr. Belaski will be making comments on our behalf. I just really want to thank you so much for having this forum. I think you know that I spent at least 10 years of my career in an agency supporting people with intellectual disabilities and their families, and I've seen the types of discrimination that has been described today firsthand. It really is unacceptable, and I'm so grateful to you for raising this as an issue more publicly and for really giving us the opportunity to raise this issue so that we can address it as an agency and as a state, because everyone deserves to live with dignity and respect, and this is a huge first step in making sure that it's more public and that what we want for every citizen happens every day. So with that, I'll turn it over to Dr. Donna Belaski so she can present our perspective as an agency. Thank you.
Thank you.
Donna, you're on mute.
Dr. Belaski, you're muted.
I'm sorry about that. Can you hear me now?
Yes.
Okay. Good afternoon, members of the Public Health and Human Services Committee. I'm very honored and humbled to be here to be able to speak to you on behalf of the agency, but also as a person who has multiple disabilities. I have a colleague that is going to do my slide presentation for you. I'm going to cover some of the things that we've spoken of and some of the things that have not been spoken of. Okay, my concentration is, healthcare for people with disabilities and some of the information that's published by the CDC and what DSS does. Next slide, please. Okay, disabilities can be present at birth or they can be acquired. There are 3 dimensions to disabilities. The physical, with an example would be something as a limb loss, and activity limitations, something which I experience is visual loss or issues with problem-solving capacities. Also, other limitations or another dimension of disability is participation restrictions in everyday living activities. It's something that you take for granted, like brushing your teeth. And I'll focus a little bit on oral health because I noticed no one has talked about oral health in the dental chair and having things like toothbrushes available to them. You can see by the prevalence of the different types of abilities in the slide, in the slide that the most common disabilities are ambulatory and developmental disabilities, which was focused on today. People often have more than one disability. Like I said, 27% of the population has a disability. And that's a pretty large number of people in the United States. It's roughly 61 million people. Next slide, please. And you've heard this before. 1 in 2 people 65 and older have a disability. 1 in 4 women have a disability. 2 out of 5 of non-Hispanic African-American population have a disability. And it's important to know racial discriminations because people of different races perceive disabilities and handle them in different manners. Next slide, please. People with disabilities have identical healthcare basic needs, as we've all heard today, as the rest of the population. But we've got the 2, 3, 4 problem. 2 times more likely have providers who do not have the appropriate care. 3 times more likely to have been denied healthcare services and 4 times more likely to be treated poorly by providers or healthcare practitioners. And I think one of the problems comes from that is office staff and support staff are not required to take any training courses talking about people working with disabilities. I think something like that would be very important to add to the curriculum. And it doesn't have to be very extensive, but something that makes them familiar with the most common type of disabilities that they will be working with. Okay, next slide, please. Disabilities and access to healthcare. You've heard 1 in 4 people do not have consistent healthcare provider. 1 in 5 adults do not have preventative checkups in the past year, and 1 in 4 adults ages 18 to 44 have unmet healthcare needs due to the cost. People with disabilities have a disproportionate amount of debt. And if you look at the statistics, 1 in 4 households of people who have people with disabilities have medical debt, unlike 14% of the households that don't have anybody with a disability living in them. Now, to underscore the importance of this, Governor Lamont released the Medical Debt Erasure Initiative, in which he announced in February. And that's very important to people with disabilities because there's a lot of ancillary costs when you have a disability to obtaining health care. We see that all the time, transportation expenses and other necessary adaptive items that you have to do in order to get your health care. Next slide, please. This one's really interesting. Self-reporting of healthcare status by people who have disability, they're more likely to report that they have poor health. Even when you stratify for educational levels, this consistency of having poor health continues to exist. People with disabilities have significant differences in risk factors for comorbid conditions. That's not present in the regular population. You've heard about the weight. Weight is very essential thing. Other areas are diabetes. Smoking is increased in a lot of people with disabilities. And there's other risk factors that exist too, because lack of mobility and they're not getting exercise. Lower rates of preventative care use happens. And then the other thing is there's more difficulty in accessing healthcare services. Next slide, please. In 1993, the Americans with Disabilities Act was passed and subsequent revisions made to help level the playing field, both in everyday life activities and access to healthcare and other forms of participation in society. This was expanded to include the Web Consortium guidelines, which were now applies to all the things that you hear of online, all the electronic devices you hear about, accessibility, Siri, those types of things. And then in 2010, the culturally and linguistically appropriate services became enacted as part of the Affordable Care Act. And that levels the playing field for people who have cultural and linguistic differences, which also apply to the disability community of people. Next slide, please. Okay, requirements from DSS, and this is just a very high level. I can give you a huge exhaustive list of what many of our administrative services organizations are doing, but this is just to highlight some of the importance that we do to help people gain more equitable healthcare services. We offer care coordination to members who have special healthcare needs, and that includes one-on-one assistance if they ask for it, and coaching assistance for appointments. In the oral health field, there's a lot of people who are afraid of going to the dentist. And the other thing with dental, a lot of offices aren't wheelchair accessible. We mark those measures to make sure people can get in. And I don't know of any offices, I have to say, that have Hoyer lifts to assist people in wheelchairs and oral health. So I hope you'll consider that too when you're making the framework for leveling the playing field. We do NEMT scheduling for our members, and that's specialty NEMT scheduling if they require, special wheelchair vans and things like that. We arrange for sign language and translation services for all of our members. We educate offices regarding treating people with disabilities or special health needs and some of the accommodations that might be needed. We teach a class over at UConn Health Center on doing this with the dental students on cultural, linguistic accessibility and ADA accessibility accommodations in an office for people with disabilities. I've been doing that for several years. Okay, next slide, please. All published materials now have ADA requirements and class standards, as I said. They're available in the most common spoken languages in Connecticut, which there's 15 of them. That's put out by the Office of Civil Rights and based on our census data. Electronic communications are required to also be compliant. And an example is an alt attribution, formerly called an alt tag, which is a description of a picture or a graphic that's contained in a presentation. Next slide, please. Some providers have specific requirements, and this is important in our NEMT services. All providers must go through the CTA PASS training, which instructs people how to work and assist people with disabilities. And then for the independent drivers that are contracted with the NEMT broker, they're required to go to special ADA training on how to assist passengers who have a disability. And one of the things that we do in dental is we educate offices on ultrasonic equipment for people who have, electronic hearing assistance devices. The new devices don't require this, but some of the old devices are highly affected by, the ultrasonics and electronics that are used in dental offices now. One of the other things that I wanted to bring out that was previously mentioned, there was a study done, and it was about helping kids transition from, pediatric offices to adulthood offices. And it's very important because often the children feel devalued, and that's across the board with everything. There was a nice study and publication done by that a couple of years ago. And we have a lot more work that we have to do everywhere. And, I know we are invested at DSS to continuing and helping to improve access for people with disabilities and make it easier. Thank you.
Thank you so much, Dr. Belaski. Thank you, Commissioner, for you and your team and your work that you're doing. We're just going to quickly move on. I know it's past 3 o'clock, so we will move on to our representative from the Office of Health Strategies, Cindy Dubuque Gallo. If you want to just share your perspective from the OHS.
Thank you for giving me the opportunity to comment today. For the audience at home, OHS's mission is to implement comprehensive, data-driven strategies that promote equal access to high-quality healthcare, control cost, and ensure better healthcare for the people of Connecticut. Just wanted to provide a few data points to this conversation. So I looked at a study, Healthcare Values Hub data brief from October 2022, and of households, including a person with at least one disability, they found that 29% avoided going altogether to a doctor or having a procedure done, as compared to 18% of households that did not include a person with a disability. 27% experienced problems with getting mental health care, as compared to 9% of households that didn't have a disability. 16% experienced problems getting addiction treatment. 38% skipped needed dental care. 23% skipped or delayed getting a medical assistive device, such as a wheelchair, a cane, a walker, or hearing aid or prosthetic limb due to cost. And 54% incurred medical debt, depleted savings, and or sacrificed basic needs due to medical bills. The Department of Public Health also has a study called Connecticut Behavioral Risk Factors Survey, Prevalence Estimates Risk Factors. And I'll share with you from there that 32% of those who reported their health as either fair or poor had a disability, compared to 5.8% And 12.8% of those who reported that they could not see a doctor when needed due to cost reported having a disability. And also 8.6 of those who reported not taking their medicine as prescribed because of the cost identified as having a disability, compared to only 3.7%. It's worth noting that it's challenging to identify people with disabilities in the claims data for the All Payers Claims Database, and therefore we are unable to examine the cost of care and spending for this important population group. Such data would enable us to better identify health disparities for those living with disabilities and speaks to the need for standard data adoption by providers and payers to include disability in addition to race, ethnicity, language, sexual orientation, and gender identity. We appreciate the efforts of the Public Health and Health and Human Service Committee to spotlight this issue. And I personally want to say that I appreciate the discussion as someone who has I'm a sibling and guardian to 2 individuals who live with intellectual and developmental disabilities. So thank you for having this conversation today.
Thank you so much, Cindy. Thank you. And the next person on our list is representing the Office of Policy and Management, Zani Amitovsky. Welcome. You're going to tell us how you're going to solve it all, right?
Yeah, I do not have the solution to all of it, but I look forward. I want to thank everyone here today who spoke. Thank the chairs. And I think on behalf of Secretary Beckham and the governor's office, we look forward to continuing conversations through this session and the budget development process. So I'll keep it short, and I look forward to talking to everybody. So thank you.
Thank you. Thank you so much for listening in and being part of the conversation. We are past our allotted time, which was 3 o'clock. I know many of the interpreters have to leave in the next 10 minutes or so. I just wanted to give an opportunity to some of my colleagues who have reached out and wanted to say a few things. And then after that, we'll just have a few closing comments from our chairs and also from our ranking members. I wanted to extend first to Dr. Gordon, Senator Gordon, for a few words that he wanted to say. Thank you.
Thank you, Mr. Chairman. I want to start out by thanking the chairs of the Public Health Committee and the Human Services Committee for hosting this forum. And I also want to say thank you to Representative D'Amico for being a leader on this issue as well. And I just want to comment that in addition to being a senator, I'm also a doctor. So I deal a lot with people who do have various forms of disabilities. And I do agree that even though the American with Disabilities Act talks about reasonable accommodations, we do need to see what more we can do realistically and responsibly to provide good health care, timely health care, and safe health care to everybody here in Connecticut, including everybody who has disabilities, no matter the type of disability or the degree of disability. And I very much look forward to working with all of you and people here in the legislature to see what we can do to move things forward. So this has been a fantastic opportunity to hear from people. And again, thank you to the chairs for hosting today's meeting.
Thank you so much. And next is Representative Kit, who had some comments and questions.
I want to echo my thanks to the chairs and to Representative D'Amico for bringing this to the forefront. This is an issue that has been part of my life for over 20 years. I live with a disability. I've been an advocate for people with disabilities for 20 years or more than 20 years. And it's something that I've lived. So I also want to extend a thank you to each and every one of the advocates who came here. I know it's not easy. In fact, one of the first times I came up to Hartford as an advocate over 7 years ago when I first moved to Connecticut, it was to talk about family medical leave and how important it is for families who are caring for loved ones with a disability and for people who live with disabilities and who need the time off from work to take care of themselves. So I just want to assure you all that you have a voice here up in Hartford, and I want you to continue the hard work and keeping us accountable and making sure that we stay on top of this issue. Thank you.
Thank you. With that, I would ask some of our ranking members and also our chairs if they want to make some closing statements. I wanted to start with Representative Lisa Seminaro. Senator, sorry.
That's okay. Thank you again to the chairs and
to all those who participated in today's forum. I recognize that it's difficult to get here and it's difficult to remain here for hours at a time. It's been quite the day, very informative if you ask me. And although I live and breathe this, I feel like I learn things over and over again with testimony and for people coming forth. So I very much appreciate that. I would like to ask one favor. If anybody who, Dr. Bruder and those who have provided testimony that included facts, resources, things of that nature, and all the departments as well, they provided some slideshows. If that can all be made available to all of us, that would be very helpful as we continue this journey to improve accessibility to healthcare in Connecticut. And I hope that this is the beginning of many, many discussions to come. And I hope it's also the beginning to us finally making a change in accessibility to healthcare. Thank you so much, everyone, for being here.
Thank you. And all of the testimonies and the information will be posted on the Public Health Committee website as well. So it will be available to anyone. I wanted to see if Representative Nicole Claridis-Dieter, you want to have some closing comments?
Thank you, Mr. Chair. I want to thank everybody for being here today and having this very informative forum. I think it's eye-opening for a lot of people that don't understand that people with disabilities don't have equal access. I find it personally disgusting that someone does not have access to be able to get a mammogram or a table that moves up and down in a doctor's office, just equal access. So I'm looking forward to the federal guidelines changing, and hopefully we can get equal access for everybody in the state of Connecticut and in the country for that matter. Thank you, Mr. Chair.
Thank you. I see Senator Summers has been listening in as well. If Senator Summers, you are able to, you're welcome to have your closing comments. And as Senator Summer moves in that direction, I'm going to ask my esteemed co-chair, Representative Kristen McCarthy-Vahey, if she has some closing comments that she wants to make.
Thanks, Senator Anwar. Just again, very briefly, thank you. Thank you to everyone who has shared your story with us. We clearly have a lot of work to do to build on the good conversations that have happened thanks to advocates like Ruth. And I appreciate you, Senator Anwar, facilitating our conversation today.
Thank you. With that, I'm just going to say a few things that I heard, and I will not necessarily be very short, but I'll try to summarize what I heard. First thing that I heard was that a status quo is unacceptable. That's one thing I heard. And the second thing is that we can do better. And then there are multiple areas where we can do better collectively. I will try to list what I heard, and one of them was on the training and an education perspective. There is an opportunity for curriculum modification and enhancement to address this issue, because the current generation and the next generation of workforce needs to improve on this end. There is a need for a culture change with empathy. Empathy means walking in somebody else's feet. And you can never walk in somebody else's feet, but work as hard as you can to be able to feel that and experience that as much as you can, so you can start to understand what needs to be done to achieve that. One is also to have the workforce at various levels to know how to transfer patients and also use Hoyer lifts and opportunities on that end. I also heard that there's opportunity for changing equipment, but the equipment changes in investment would require the federal government to weigh in on that, because if the federal regulations change, you cannot have a different equipment in different states. And the federal government, I know, is going to be a little slow in this. So what do we do in the interim? We cannot just not do anything. So I think we need to look at making sure that the easy things can be done where the space is an issue. Whatever the federal regulation will be, you will need space. And then whatever the federal regulation will be, you will need some height adjustable lifts. You will need Hoyer lifts. You will need personnel to be able to help get patients get into the right position for appropriate testing. So those things do not require the federal government to weigh in. So I think that's something that we can start to look at as what I heard. And then making sure that there is some funding available to help out. I don't think we'll be able to get that question right now because of the time limitation, but one of the thought would be, can Medicaid funding be increased for individuals who are experiencing disabilities to be able to provide that? Because that would help the investments to be made and then provide the services. Because if there is no support available from Medicare and Medicaid, because most of the patients may be in that position, then we need to have some support available and then be able to achieve that. So that's something that's important. With respect to the doctor's offices, I think weighing scales and an option that we need to have, and then also have the staff and an appropriate training for the staff. I heard that the GI procedures is something that's an important issue. You cannot have somebody have the cancer screenings not be equally accessible to individuals. That's something that needs to be improved. Communication strategies for individuals who need help with communication. That may not need a federal regulation. That could actually be something that we can look at. And better font and written information for patients should be in the appropriate fonts for them to be able to read them. And then access to documents that they would need from that point of view. Help with positioning, having one large room in every office may be an appropriate request or a plan in future. It may not necessarily be regulated, but that's something that people should start to look at. You cannot have every office be handicap accessible, but you need to have at least one office be handicap accessible so that you can use that when the person who comes in with the needs to be able to address those. I think those are aspects on structural changes, cultural changes, and opportunities. I hope that this conversation and the efforts of all the people who have come together would lead us to be in a better place to hopefully in the upcoming session have real policy conversations and act on this, and then look at this as a journey that we should begin. We should absolutely begin this journey this session, and the journey will have to continue because there are so many more things that need to be done for that. So with that, I will say thank you for each and everyone who's participated with your heart, with your love, with your care for not only yourselves, but for your family and friends. Thank you again. And thank you, Representative Miko, for making sure that we do this. Thank you.